Welcome to HITea with Grace, where we spill the tea on HIT. Today, I'm honored to welcome to the pod Dr. Sarah E. Matt, healthcare strategist, best-selling author, ex-Oracle. Thanks for joining us today, Dr. Sarah.
Thanks for having me, Grace.
So everyone's talking about AI in 2026, but you argue the real story is a rural renaissance happening quietly in the background. So spill the tea. Where is capital actually flowing right now when it comes to hospitals? And where do people think it's flowing, but it isn't?
So I think right now everyone thinks that delivery systems like hospitals, rural health, you name it, are investing in AI right now. What I would say is that's not the case. So they're absolutely checking it out. They're absolutely trying to determine when and where they should implement it. But I'd say that a lot of hospital systems, especially in rural environments, are really looking at their infrastructure. So can they actually take those amazing AI products and solutions and make them work in their system? A lot of places are realizing that, first of all, their data governance is not up to snuff, and therefore it'll be very hard for their AI governance to be solid. Secondly, a lot of their patients don't have the high bandwidth necessary for a lot of the solutions that are out in the market for telehealth, RPM, you name it. And a lot of hospital systems, especially in rural environments, don't have amazing infrastructure for their own facilities as well. So I'd say that while everyone thinks the money's going to AI from a healthcare delivery standpoint, I'd suggest that folks are actually looking more inwards at their data strategy and their infrastructure.
Fascinating to think of it that way, honestly, because you just hear AI, and it's like, well, what's actually happening in reality? And you've said in the past, geography is history, yet zip code still predicts life expectancy and in critical things of that nature. So why do so many well-funded digital health pilots collapse the moment they hit the reality of a rural ER or a rural EHR on a Tuesday night?
So I've been in product development my whole career, and it's really easy to think that patients and the environments they're in are just like yours, whether you're in Seattle or New York City or LA. You assume things as a builder. Oh, they must have a phone like me. Oh, they must have internet like me, but they don't. And I think that when we're building, we're thinking about the latest and greatest, but we're not necessarily thinking about our real customers. So yes, hospital systems will often pay for patient engagement tools, telehealth, et cetera. But the users, the consumers, are not necessarily your high income users. We're talking about real people here that live in environments where there's spotty Wi-Fi, where they may not have data on their phone, and where their internet, their house is maybe not so great. And so if we're only building solutions for 5G, latest iPhone, and fiber, it's not going to work for every patient. So it really depends on who your users are going to be. So instead of just delivering solutions for the people with the latest tech, consider who your hospital systems need to service. They're servicing a wide variety of patients. And a lot of them are probably using older Androids, may not have amazing internet in their homes or at all. And we have to also build for those offline situations.
Absolutely. That makes a ton of sense. I've been watching that show, The Pit, and I'm sure a lot of this audience has been watching that show, and you see so much that trend of physician burnout. And we talk about digital infrastructure all the time until we're blue in the face, but I have heard you talk a lot about human infrastructure. So what do you think is the most really misunderstood or really ignored trend in this kind of when we think about physician burnout, that hospital boards are kind of missing this year?
I think people forget that doctors and nurses are people too. I'm always asked all over the place, well, what can doctors and nurses do better to improve patient engagement? Or what can doctors and nurses do for X, Y, or Z? How about we have the doctors and nurses do a little less? So right now, they're in a really tough spot. As part of these systems, they have to see so many patients in a day, an uncomfortable amount of patients in a day. And it's really hard, if you've ever been in customer service, hospitality, retail, you name it, to serve that many people with the absolute best of yourself every single day. So what I'd say is that when we're burning out physicians, nurses, and other healthcare folks in the ecosystem, it's not just because of clicks. It's not just because of ill people. It's because we're expecting them to do more and more with less and less. So we're expecting providers to provide A+ customer service, be able to diagnose today, and be able to make sure everything's safe, et cetera, plus do all the administrative work. Whereas 5 years ago, we could have cranky doctors. 10 years ago, we didn't bother with all the checkboxes. And so what I'd say is that we're expecting more and more out of a group of people that are having less and less support and are feeling the squeeze. So while there's lots of different components here, I'd say, hey, people working in healthcare are people too. We need to treat them that way.
Absolutely. Amen, sister. I'm sure everybody on the other side is like snapping their fingers like you totally have that right. So let's talk about your book, The Borderless Healthcare Revolution. Tell me a little bit about the book, what, came, how did it come about? And tell us about how it challenges that idea that care really needs walls, even. And how does that kind of play into this as well?
Yeah. So I wrote this book this past year, and it's all about healthcare access and how technology can decrease barriers to care, but also how it can produce new ones as well, because I think we forget that technology isn't always our saving grace. Now, the reason I wrote this book is that when I started writing at the end of 24, the United States has been in a really polarized time. Everyone's really disgruntled about healthcare, about a lot of different things. But I wanted to write something that would be both impactful and bring people together, because when we make things so decisive that we can't talk to one another, I feel like we forget that we can solve big problems when we all get on board. And healthcare access is one of those topics where no matter what room you're in, no matter who you talk to, what economic group, what place they've been growing up in, anything, everyone has a terrible healthcare access story for themselves, their parents, their kids, their friends. And so for me, it's something we can all kind of come together on. Now, what do I mean by borderless? I think a lot of people think of the geography problem as the biggest access issue in healthcare, but I actually break access down into 5 big pillars: geography, financial, cultural, trust and knowledge, and digital. And if we look at any problems that patients are having with the system, or even doctors, nurses, and administrators are having with the system of healthcare, it often has to do with one of those pillars. So for me, I'd like to break down those barriers so that we don't have these invisible walls, these borders between people in different parts of the United States or the world, between people making different amounts of money, people with different insurances. How can we produce care for everyone?
Isn't that just like the dream? Everybody could have access to care. You think about that in rural environments and urban environments, and like, what does it take? How can technology help support that effort? And I think health systems are really trying, it seems. It's like they're trying to keep their margins, they're trying to pilot different innovations, and yet they're really terrible at scaling these innovations. And what separates the rural hospitals that successfully adopt new models of care and from those that are becoming kind of permanent pilot graveyards of sorts?
That's a great question. And I see a lot of health systems, no matter if they're rural, urban, big or small, everyone's in this state of what I call pilotitis, the infection of pilots. We have pilot after pilot, but none of them stick. And I say the first piece of that is we call them a pilot. So there's that kind of thought process that, oh, this is just temporary. We're not going to keep this. But when you call the implementation of a new innovation or solution phase 1, it gives a different implication, especially for all the folks that are listening on the tech side. Hey, phase 1 means we're going to keep this in. This means we're going to build on it. This means we're going to improve it. Pilot means, well, in 30, 60, whatever days, we're getting rid of this. So why am I going to invest my time? The other thought here is that a lot of times we're shoving new solutions into an environment that's already completely stressed out. So when we ask a provider, a nurse, a pharmacist to do 10 extra things because we think it'll be easier, because we think it'll be better, you're going to get instant chaos and instant pushback. One thing from a product management perspective that we oftentimes forget is that while we may have designed the technology in a great fashion, sleek, you name it, it still might not be either A, solving the real problems of the boots on the ground people, or B, actually work within workflows and the reality of the healthcare system. I can't burn down the system and build it from scratch. I have to work within what we have already. So if your solution, you're trying to shove that round peg into that square hole, it's not going to work. You have to make sure you've designed it from the get-go to work within the existing systems. I see a lot of tech companies and startup founders come to me and they're like, I have this amazing AI, I have this amazing product, but it's not integrated to anything. They have no plan to put it into a normal workflow. And unless they have a real commitment to doing that at some point and putting it within existing systems, I find it's going to be very hard for them to succeed.
When we're really thinking ahead to 2027, 2028, what's the uncomfortable truth that health system leaders don't want to really admit about the future of rural hospitals? And who's preparing for it quietly? And also, like, why rural renaissance? Are things like totally failing in rural hospitals and rural health? Or is there so much promise? And what are we missing?
So I'd say the unsaid truth of healthcare in general, and especially of rural medicine, is that it's a business. We have to cover costs. And when you're in a rural environment, there's just less people coming through the door. But these are people who need the care. It also means there's less people there to work as nurses, doctors, staff members. I actually see patients in a charity clinic in rural New York here in upstate. And we've had a really hard time referring to get an ultrasound because all the ultrasound techs quit except like one. And you would think, oh, well, but it's a hospital in a rural environment. They got to have someone to do an ultrasound. No, they're down to one. And it's because there just aren't enough people to hire in that environment without having them drive long distances. So it's hard for some of these rural hospitals because of numbers to stay in business. They need people to do the work and they need enough throughput to make sure that they can cover their costs. So I think the first thing is that we have to remember that healthcare is a business. If you were running a car dealership or a restaurant and you couldn't get people to serve the food or sell the cars, and you couldn't get people to come buy the food or buy the cars, you'd close down. And that's how it is too in some of these rural environments. Now, when I see the thoughts on a rural renaissance, it's because I'm ultimately an optimist here. The people in these environments need care. And I think that there's new models we can utilize with the advancements of remote patient monitoring, telemedicine, remote specialties, et cetera. I think there's really interesting ways for us to take maybe a smaller footprint, maybe not a huge hospital, but a smaller footprint with a smaller number of staff to actually do great care and facilitate some of that remote technology and some of the other pieces like RPM to care for that same population and give them access to care they may not have had before without all the travel. At the same time, I don't know if a lot of these rural environments are going to truly be able to keep their current model and succeed. Many infrastructure, I'm hoping that some of that money will be truly used to help with fiber, to help with satellite, to help with the things we need so the technologies we need to scale less people to do more work can actually get implemented properly.
So inspiring, so inspiring. And it is good to see so much money being poured in through the rural health bills and different things into this idea that maybe we can help support these communities to better have healthcare access and more. So now my listeners love to learn about what's going on in healthcare technology, but they also love to learn about what drives women leaders like yourself. So on a personal level, I'm wondering, what are things that you do in your personal life as you're kind of driving forward as the leader in this industry to work your best and make a difference?
So for me, I'm a surgeon by training, but I switched into tech early in my career. But I've never dropped patient care from my portfolio of things I do. So I still go to a charity clinic a couple times a month here in upstate New York and see patients. Why? Because I like patients, because I actually am a great doctor a couple times a month, but 7 days a week, I'm real cranky. So when I think about some of the things that I think are important to me as a leader in healthcare and health tech, putting myself in a clinic with real people keeps me grounded. Mm-hmm. The other thing is that I've really tried to, I'd say, form those relationships across time zones, continents, et cetera, because today collaboration is the ultimate currency. So when you're trying to solve a problem, if you start from ground zero it's going to take you a long time. And slow is the enemy of fast in 2026. So I have a huge network of people I've been working with for decades. And so because I have formed those relationships, I can not only call on my colleagues to ask for their advice for difficult problems, but I do the same for them. And so having that network of people that can watch each other's back and help with problem solving, I think is really important. It's really hard, especially for female executives, because I know when I was coming through the ranks, I didn't have a lot of mentors. It was hard. But what can I do? I can be mentors to other people. And that continues to breed new generations of mentors. And again, that culture of collaboration.
If you could give your younger self a piece of advice, what would you tell her?
I would tell her to chill the F out. It's going to be fine, because we get so stressed out about so many things. But I think the best thing I've done in my career is continue to learn, evolve with the times, and remain curious, so that when those opportunities arise that you didn't even know could exist, you can be open to taking them and saying yes.
To finish this conversation off right, where can our listeners find you online?
So you can connect with me on LinkedIn. That's my primary platform. And then my website is drsarahmatt.com. And all my information's there. I would love to collaborate with people. I do a lot of speaking. I do a lot of fractional C-suite. And I'd love to talk more about my book.
That's terrific. Now, before I forget, did you happen to bring tea with you today? And if so, can you tell me a little bit about your mug?
So I am using my absolute favorite teacup today. It is a pink cup. It has mushrooms on the front and it says, shiitake happens. I am drinking ginger tea, which is my go-to every day.
Ginger tea is so good for you. I've heard there's so many health benefits. Have you experienced that?
I don't know if I've experienced it, but it definitely helps me not drink too much caffeine throughout the day. That's for sure.
Yeah, I love that. I love that. It's too good. Well, thank you so much for joining us today. I appreciate you having on here, and we love learning from you.
Thanks so much, Grace. Let's do it again.
And thanks to you folks for joining us too. Check out the HITea With Grace podcast website for more interviews with great guests like Dr. Sarah Matt today. Cheers.
Like a Girl Media is more than a media network. It's a community. We want to meet you and amplify your voice and the voices of outstanding women innovating in healthcare. Interested in starting your own podcast or hosting an event near you? Connect with us online or in person. We're here to support and empower you.